Ishita Pandey? Yeah. So you can start your talk. And after that, we have got Dr. Oinam Somapika. Is she there? Okay. So Ishita, you start. Yeah.
Hello.
Then we have Dr. Deepak Agarwal. Yes, he is there. Dr. Meha Kanta. Okay. Thank you.
She can start.
Yes, yes.
Good afternoon, respected chairperson, sir, on the audience. I'm Dr. Ishita Pandey, third year PGT from IGRIM, Shillong. I'm here to present my thesis topic, that was comparison of Hill RBF3, Barrett Universal 2, Higgins and third generation intraocular lens formulas to predict the accuracy of post-cataract surgery refractive outcomes in Indian eyes. There's no conflict of interest. Introduction. Very precise preoperative biometric values are required to achieve the best post-cataract surgery refractive outcome. However, there is not a single study done to compare Hill RBF3 with the other IOL power formulas like Barrett Universal 2, Higgins and third generation formulas in Indian eyes. Such studies have been conducted in other races but not in Indian eyes till date. Material and method. Study design, we did a prospective observation study at a tertiary care center. Population, a total of 219 eyes of 173 patients that underwent uneventful phaco with PC-IOL implantation. Period was between May 1, 2021 to October 31, 2022. Instrument used was IOL Master 500 Carl Zeiss Meditech AG. Inclusion criteria was uncomplicated age-rated cataract, age being more than 40 years, and patients who underwent uneventful phaco with PC-IOL implantation and cases where optical biometry was possible were included. Exclusion criteria was corneal astigmatism more than one diopter, prior corneal refractive surgeries, prior intraocular surgeries, and pre-existing ocular diseases affecting post-op refractions were excluded. So the final post-op refraction at 1 month follow-up was expressed as spherical equivalent. The prediction error was then calculated by we did actual post-op spherical equivalent minus predicted post-op refraction, and then from there we calculated the mean and the median absolute prediction errors, and we used them to compare the post-operative predictability of each formula. We had done statistical analysis using SPSS software for Windows version 22.0, and we had measured the difference in the absolute prediction errors in post-operative refraction and comparison between the mean absolute errors of two formulas via these formulas as we can see here, and we also calculated percentage of eyes that had predicted refractive error of within plus minus 0.25, plus minus 0.5, plus minus 0.75, plus minus 1 and more than plus minus 1 diopter target refraction. Results, the mean age was 63.66 years, total of 219 eyes of 173 patients, out of which males were 88 and females were 85, and the mean axial length was 23.17 millimeter. The pre-op BCVA in 117 eyes was more than 6 by 18, while in 102 eyes was less than 6 by 18. After the surgery, the BCVA in 216 eyes was between 6 by 6 to 6 by 9, and in 3 eyes it was between 6 by 12 to 6 by 18. We had divided our population based on axial length, as we can see here in the chart. Blue color depicts group A, which is population having axial length less than 22 millimeter. The red color depicts group B, that is population between 22 to 24.5 millimeter of axial length. And green color depicts the population, that is group C, having axial length more than 24.5 millimeter. We are implanted monofocal IOLs in 90% of the cases, while we are implanted 10% in 10% population only trifocal IOLs. So to know the accuracy of the formulas, we needed to know which formula gave the lowest mean and median absolute errors. So what we found that was for overall wide range of excellence, it was Barrett universal 2 that gave the lowest values of absolute errors. For short excellence, as we can see here in this graph plotted, it was Hill-Harvey 3 that gave the lowest values for the mean and median absolute errors. For nominal excellence, it was Barrett universal 2 that gave the lowest values, and for long excellence, it was SRKT that gave the lowest values of absolute errors. We also got to know that Barrett universal 2 had the largest percentage of I's within plus minus 0.25, plus minus 0.75 and plus minus 1 diopter of target refraction. However, Hill-Harvey 3 had the largest percentage of I's, that is 88.1% within plus minus 0.5 diopter of target refraction. Discussion. This is the first study to compare the post-phacoemulsification refractive results using Hill-Harvey 3 with Barrett universal 2, Hagees and third generation formulas in Indian eyes. Many studies have found that Barrett universal 2 stands as the most accurate formula over a wide range of excellence. Study by Cellar and et al. Was the only study done so far where Hill-Harvey 3 was compared with the other formulas. What we found in our study was Barrett universal 2 was the most accurate IL power formula over a wide range of excellence in Indian eyes, followed by Hill-Harvey 3. Hill-Harvey 3 and SRKT were found to be most accurate IL power formulas for short and long excellence respectively. Limitation was that astigmatism more than 1 diopter cylinder were not taken into consideration, and a smaller number of population were present in the short and long excellence groups. Conclusion. So in our study we found that Barrett universal 2 was the most accurate IL power formula over a wide range of excellence in Indian eyes, and it was also the most accurate formula for predicting errors within plus minus 0.25, plus minus 0.75 and plus minus 1 diopter of target refraction. However, Hill-Harvey 3 was the most accurate formula for predicting errors within plus minus 0.5 diopter of target refraction. Hill-Harvey 3 and SRKT were found to be most accurate for short and long excellence respectively. It is hoped that the outcome of this study will help the surgeons to choose the best IOL powers for their patients by utilizing the best IOL power calculation formulas, thereby helping the patients to get the best refractive outcomes. Thank you.
Thank you, Dishita. Actually, in spite of all efforts, many times we land up in surprises.
Yes.
We wish that there were just one single formula which would have covered all the grades of cataracts. So thank you very much.
I think there's a software with the artificial intelligence this thing.
Yes, sir.
Which integrates all the formulas and then gives you a single formula for either a short, medium and long excellence.
Yes.
Okay, sir.
So instead of going for selecting for long and short eyes, just have a single formula which incorporates almost all the formulas and gives you a result.
Thank you, sir.
Thank you, thank you. Next I invite Dr. Oinam Samapika Devi. She is going to speak on clinical pattern and burden of strabismus in a tertiary care institute of Northeast India.
Respected esteemed delegates on DAL and all the distinguished guests gathered here today. The title of my presentation is Clinical Pattern and Burden of Strabismus in a Tertiary Care Institute of Northeast India. Introducing the study, the complex sense of vision works best when the eyes are aligned to give binocular single vision with simultaneous perception, fusion and stereopsis. A person with strabismus not only has low self-esteem due to misaligned eyes, but also never gets to appreciate all the grades of binocular single vision. The worst part is the person may suffer from amblyopia. To the best of our knowledge, there is no study that states the clinical pattern and burden of strabismus in Northeast India. So the purpose of our study was to find the clinical pattern and burden of strabismus in a tertiary care institute of Northeast India. It was a hospital-based cross-sectional study which included patients with manifest strabismus of all age groups. Clinical history was taken, visual acuity and refraction was done, anterior segment and posterior segment were evaluated, strabismus evaluation including extraocular movement, measured deviation, tests for sensory status and stereopsis were done. The result, 110 patients with manifest strabismus were identified and included in the study out of 27293 OPD attendance between May 2021 and October 2022. So, the hospital-based prevalence was found to be 0.4%. The mean age of the study population was 27.16 years, male outnumbered female comprising 55.45% of the study population. Committant strabismus was the most common strabismus, comprising 84.55% and incommittant 15.45%. Exotropia was the most common deviation, comprising 70%, esotropia 26.36%, hypertropia 10%, hypertropia 2.72%. Among the exotropes, constant was the most common form seen, and among the esotropes, non-accommodative type was the most common form seen. The mean angle of deviation for horizontal deviation was found to be 34.90 prism diopter and 13.29 prism diopter for vertical deviation. Among the causes of strabismus, paralytic cause was seen in 15.45%, sensory in 11.82%, infantile and accommodative in 1.82% each. Myopia was found to be the most common refractive error, and hypermetropia after that. Myopia was seen in 23.64% and hypermetropia in 14.55%. Amblyopia was seen in 1.82% of the patient. And in the treatment, 74.55% of the patients were treated conservatively and 25.45% underwent surgery. It was noticed that among 74.55% patients managed conservatively, 13.64 were advised surgery, but they denied surgery. These are some of the data from our country and other countries on strabismus. It was seen that the distribution and pattern of strabismus varies from region to region of the world. In our study, the prevalence was found to be low, which could be attributed to the fact that it was carried out in a relatively new tertiary care institute of Northeast India. However, the pattern of strabismus was similar to most of the studies. During the studies, it was learned that there is lack of data on strabismus. Most of the strabismus studies are done in pediatric age groups. So there is need of studies including other age groups apart from pediatric age group. Different studies classify strabismus in different ways. So at present, there is no standard classification of strabismus. And most important of all, there is lack of awareness on strabismus, its effects, and its available treatment option. People are skeptical about undergoing strabismus surgeries. Limitation of the study. Present study has defined hospital-based prevalence of strabismus in Northeast India, and it did not include 4 years. I would like to conclude by stating that with our study, we have tried to highlight the pattern and burden of strabismus in a Tertiary Care Institute of Northeast India, which indirectly gives the picture of entire Northeast. It is hoped that the findings from our study will help in tackling the morbidities associated with strabismus and guide the healthcare planners to take the necessary steps. Thank you.
Thank you. This is a real practical problem, especially in places like yours. How do you have all subspecialties in your institute?
Sir, not all. So right now we have glaucoma, medical retina, strabismus, and pediatric clinics. Pediatric ophthalmology. So we are trying for cornea and retina.
And awareness is differently because many a times the patients coming from rural areas, they take it for granted that God gifted has nothing can be done, and they come very late. Especially girl child, they will come when they will feel that now we are thinking of going for marriage. So then only they will, by the time she develops amblyopia and everything. So this is a real challenge.
Hospital-based prevalence is not the right type of study for this particular problem.
Okay. Thank you very much.
Thank you, sir.
What was your sample size? What was your
So we got 110 patients, sir. Yes, sir. Sorry. So 110 patients.
So that paralytic was more.
Yes, sir. Like among the whatever we could identify, the identifiable causes. So we could get so like elderly patients.
No, in that case,
Paralytic is more means they are all referred to
So neuro, yes, sir, neuro and ophthalmology.
treatment.
Good afternoon, respected chairpersons and delegates here. I'm going to talk on endogenous endophthalmitis. As you know that with the important risk factors, I think as you know, endogenous endophthalmitis is a rare disorder where the infection spreads to the eye through the bloodstream. The important risk factors are long-term indwelling catheters, intravenous drug abuse, chronic immunosuppression, debilitating diseases, extraocular source of infection like tooth abscess, pneumonia, endocarditis, urinary tract infection, meningitis, liver abscess. In the COVID era, the long term, we found that long duration admission in an intensive care unit led to an immunocompromised state of the patient, diabetes secondary to the high dose systemic steroids given to treat pneumonia and intravenous lines maintained for several days was implicated. So you can see here, these are pictures of some patients which were from the post-COVID era where the patient had developed endogenous endophthalmitis, and the worst part is that it was often misdiagnosed as patients of uveitis, and when the response to the treatment was not there, they were labeled as endogenous endophthalmitis secondary to bacterial or fungal infection, leading to a delay in their appropriate treatment. So the important organisms implicated are Staphylococcus aureus, the most important risk factors being diabetes mellitus, renal failure, intravenous catheters, and AV fistula. The source of sepsis being the skin and septic arthritis. Streptococcus secondly, with the source of sepsis being meningitis and skin infection. Bacillus cereus in cases of intravenous drug abuse. Klebsiella pneumonia in diabetic patients, and importantly hepatobiliary disease, UTI, and prostatitis. E. coli in diabetes mellitus and urinary tract infection. Candida in intravenous drug abuse following GI surgery and long-term broad-spectrum antibiotic use. Aspergillus in chronic pulmonary disease and IV drug abuse. So one of the most important features for the diagnosis of endogenous endophthalmitis is to ask the history. There would be a history of some admission in the hospital, and that would give us an index of suspicion that this is a case of endogenous endophthalmitis. So the infectious agent travels via the bloodstream and multiplies in the choroid, eventually infiltrating the retina and spreading into the vitreous. Clinical features will include eyelid injection, circumcorneal congestion, corneal edema, hypopyon, and absent red reflex and vitreous cells. In the fundus, there may be vitreous haze and vasculitis. This is a picture of Aspergillus endophthalmitis, which shows a characteristic central macular chorioretinal inflammatory lesion, a pseudo-hypopyon over here. That is because of the gravitational layering of inflammatory exudates in the subhyaloid or subretinal space. Other associated features include retinal vascular occlusion, choroidal vascular occlusion, and exudative retinal detachment. Anatomical, it can be classified into focal, anterior diffuse, posterior diffuse, and panophthalmitis. Fungal endophthalmitis can be classified into stage 1 chorioretinal changes without extension into the vitreous cavity, fungal mass penetrating through the internal limiting membrane, vitreous opacity resulting in a blurred fundus, and fourth one is again a vitreous opacity actually obscuring the fundus. So the differential diagnosis includes uveitis, it can be uveitis, anterior or posterior, tumor necrosis with inflammation, retinoblastoma, disseminated toxoplasmosis, and disseminated viral retinitis. So management would include evaluation of the degree of ocular involvement, identify the causative organism underlying the primary source of infection, and most importantly, in endogenous endophthalmitis, one must treat the systemic infection. Just giving local treatment intravitreal will lead to a recurrence. So So referral to an internist for systemic evaluation is very important to locate the primary source of infection. Investigations include a B scan if the media is not clear. There will be low to moderate reflective dot and membranous echoes over here. There can be evidence of choroidal abscess, which can be seen as dome-shaped lesions arising from the choroid, as seen here. There can be exudative retinal detachment, which is seen as a high reflective membrane attached to the optic nerve head over here with limited after movement. And this can progress to a closed funnel retinal detachment in chronic and fulminant cases. In the OCT, one can, if the media permits, one can see posterior vitreous cells. So this is the vitreous here, and you can see these dots here, which suggest that the patient is having vitreous cells. There can be cystoid macular edema, and there can be a subretinal abscess or choroidal thickening. So the investigations performed is basically to collect the sample for microbiological examination, blood culture, urine culture, AC tap should be done prior to starting of topical antibiotics. Diagnostic vitrectomy should be done, and the samples can be sent for RT-PCR. Systemic pharmacotherapy, like I mentioned, is very important. Oral ciprofloxacin, intravenous cefotaxime, and gentamicin can be started, and this can be modified according to the culture sensitivity report. The doses of the antifungals are here. The fluconazole 400-800 milligram for Candida. Voriconazole is a very strong antifungal and it works very well. A dose of 200 milligram BD is given. Only thing is it is a bit costly, and the minimum duration for which the systemic antifungal therapy should be used is 6 weeks. But the period can be extended depending on the response and resolution of the lesion. Intravitreal pharmacotherapy, the doses are the same as for post-operative endophthalmitis as mentioned here. Role of steroids, again there are no clear guidelines, but intravitreal steroids can help by decreasing the inflammation, and it should be given in cases of bacterial endogenous endophthalmitis. However, first the antimicrobial should be started, and after that corticosteroids can be started. Surgical treatment is recommended for patients with severe vision-threatening Candida, Aspergillus, and bacterial endophthalmitis. There are better outcomes now in the MIVS era, and the dual role of diagnostic and therapy intervention is there with the surgical involvement. It provides a good amount of sample for culture sensitivity and also reduces the infectious load. Only thing is the prognosis may be very poor, and there may be complete loss of vision if the treatment is delayed, and high clinic, as I mentioned, a high index of suspicion is needed for the diagnosis. A prompt diagnosis and appropriate treatment can salvage useful vision. So the take-home message here is a prompt diagnosis of the underlying cause of endogenous endophthalmitis along with the control of eye infection is most important, and proper counseling of the patient regarding the prognosis should be done, and informed consent should be taken before any intervention. Thank you. So most important thing is that in endogenous endophthalmitis, systemic treatment is the major treatment actually, and one should not just rely on local treatment, because just treating the eye locally, it may respond that time, but there's going to be a recurrence. So systemic antibiotics are very important in endogenous endophthalmitis. Thank you.
Thank you, Deepak, for giving nice tips. And you know, this is a real nightmare for all anterior segment surgeons, and the prompt action, immediate action, and prompt referral to the specialist is the seat anchor of the treatment. Thank you very much. Next, I am going to call Dr. Meha Kanta. She is going to speak on OCT angiography and emerging diagnostic tool.
Good afternoon, respected chairperson and delegates. So today I'm going to talk about OCT angiography, which is an emerging diagnostic tool in retinal vascular pathologies. So first, we all know that with the advent of OCT in the year 1996, there was it almost revolutionized our understanding of retinal pathologies and retinal diseases, because we could visualize the layers of the retina, understand the pathogenesis of diseases, and find out where the diseases start from. So even the OCT, it evolved over the years till the year 2006, when we got the spectral domain OCT, which was a very high resolution OCT. You could see all the layers of the retina and the choroid very clearly, and obviously it improved our understanding and prognosticating of diseases. So, but there was one lacuna here. We could see the anatomically, the structures and the diseases, but no vascular pathologies could be seen. Vascular changes could not be appreciated on the OCT. For that, for many decades, we had the dye-based angiography, that is the fluorescein angiography and the ICG, but they also had their limitations. So it was a desire that together the structural morphology and the vascular changes could be seen. So with that desire, basically OCT angio came. People say that you must always be able to predict what's next. And once you know that, then we have the flexibility to evolve. So because we wanted to see them together, then came the emergence of OCTA, which was an OCT angiography. It combined both the features of the OCT and the angiogram, which made the understanding of the disease in totality much more better. So as I said, OCTA is the beginning of a promising future of retinal vascular imaging. The highlights of OCTA is it's non-invasive, you don't need any dye. There's a very accurate visualization of both the retinal and the choroidal vasculature, and most importantly in our practice, it is reproducible and repeatable without any risks. So does that mean that angiography is not required, or FFA and dye-based angiography is now a lost diagnostic tool? No. Angiography, OCTA does not replace FFA and ICG. They have their own advantages, but obviously it is a new tool which has been added, which helps in diagnosis much better. Now, why was dye-based not enough, or it had its shortcomings? It was because it was invasive. We had to give dye. And we all know that the dye had potential for allergic reactions, even life-threatening anaphylaxis. It was time-consuming, and angiography was two-dimensional. It only focused on the superficial retinal circulation. Deep retinal circulation was never very clearly appreciated on an FFA. And ICG was focused on choroidal imaging. So together, both the retinal and the choroidal vasculature could not be appreciated on ICG also. So this is an image in which you can see it's a diabetic patient, 47-year-old diabetic patient, and below is also another diabetic patient. What do you see? Let's go on figure A. It's an angiogram where you can see leaking microaneurysms, distorted FAS, few capillary non-perfusion areas. So what happens in an angiogram? Because of the leaking microaneurysms, your FAS is distorted. You cannot really appreciate how distorted is it, or how much is the ischemic area. Also, we have the problem of blocked fluorescence. If you have hemorrhages, then you don't see below that. And B and C are superficial capillary plexus and deep capillary plexus seen on an OCT angiogram. You can see because of the lack of leakage, which does not happen, the FAS is much clearly appreciated. You can quantify it, and therefore you can prognosticate the case much better. Similarly, D also, you can see the angiographic picture and the corresponding OCTA pictures, E and F, of the superficial and the deep capillary plexus, where non-perfusion areas are much better seen because of lack of obscuration of leakage. So, but still, before we go ahead, so that you don't think that it has all the advantages, and the conventional dye angiography does not have advantages compared to OCTA. So I'm highlighting a few points which still the FFA and the ICG do better. Like actual leakage. Just now I said that leakage does not happen, so actually we can see the FAS and the non-perfusion areas better. But sometimes you want to see the leakage. If you're dealing with a CSCR and you want to find the leakage, it's non-responding, then OCTA still very clearly does not define that. So we do a conventional angiogram to see the type of leak and where it is. Field. Wider fields are seen by angiogram and ICG. There's still limited field is in OCTA. So even the classic 8x8 which we do, you don't see a more than 30 to 45 degree field. Artifacts, we'll come to that later. OCT angiogram has a lot of artifacts. So if you're not trained or well versed with its, sometimes you can also read it wrongly. Now there's better visualization of low flow lesions like microaneurysms. To understand it, we will first go to the principle. One second. Now, first we'll come back to how OCTA works. OCTA basically works on motion contrast detection. That means, in simple words, it picks up the RBC flow. What it does, it takes repeated B scans on a single location and it picks up the difference in the blood flow. The difference in the blood flow is rendered into a 3D scan and there you get the OCT angio. So blood flow is very important. The movement of erythrocytes is actually what the OCT angio picks up. So when you have low flow lesions like microaneurysms or lesions in which there is no blood flow, visualization is very poor with OCTA because it is highly motion sensitive. Also, like typical OCT, the poor visual acuity and fixation problems sometimes make OCTA different. If you have a dense cataract, poor fixation, then angiography is better than doing a OCTA. So to understand and interpret for a person, like let's see a simple anterior segment or people who are not doing retina regularly, if you see an OCTA image, how do you interpret it? Actually, we see all the 4 retinal vascular layers. The 4 retinal vascular layers are A, the superficial capillary plexus, which is from the internal limiting membrane to the inner plexiform layer. B is the deep retinal vessels, which are from the internal plexiform layer to the outer plexiform layer. C, as you can see, outer retina is avascular. Why? Because we have no blood supply here, so OCTA is not going to pick up any images. So C is generally seen as a avascular area. So you know when you have CNVMs in this area, they are picked up very beautifully because suddenly you see the presence of a membrane where nothing was there because there is no blood flow there. And D is the chorocapillaris, which is 30 to 60 micron below the RP. So in a typical OCTA, you will see all these 4, which will help you identify where the vascular anomaly is in the superficial layer, the deep layer, or towards the outer retina and the chorocapillaris. So I'll just briefly touch upon a few diseases we see in routine and how OCTA helps in that. So in diabetes, the role of OCTA in diabetes. As I said, you can see microaneurysms here. The arrows point towards the hyperreflective dots. So these are the microaneurysms, but again I'll mention that they're seen very clearly, but they're not picked up totally because they are low flow lesions. So OCTA may not pick up all the microaneurysms, though they are very clearly seen. It helps us to see retinal neovascularization and the plane of neovascularization very clearly. Figure A shows an angiogram where you can see multiple new vessels. Figure B is the OCTA image of that, where you can see the CFAN beautiful neovascularization around a capillary non-perfusion area. And the plane, you can correlate it with the plane in the structural OCT. The red area which shows the blood flow clearly shows that it is above the ILM, in the hyaloid, above the ILM around the anterior hyaloid area, which shows the neovascularization. So sometimes in an angiogram it is difficult to distinguish between an IRMA and a neovascularization, a subtle neovascularization. OCTA is very good in that because it helps us to see the plane. If the IRMAs are normally at the plane of the retinal vessels, and the neovascularization will be above. It will be above the ILM. So it really helps us to see the plane of neovascularization. Plus one more thing, if it's a very profusely leaking neovascularization, then you don't get to see how big it is and exactly where it's spreading because it's obscured by the dye. But because an OCTA does not leak, so the extent and the degree of neovascularization is much better visualized by an OCT angio. The FAS, as we said, is very clearly defined and quantified because of absence of leakage. Now, CNVM and OCTA, I think the most important role which OCT angio has is in identification, prognostication, management and follow-up of CNVM because of the outer retinal vasculature is so clearly visualized by the OCT angio. So just a simple picture of a patient with a type 2 CNVM. You can see first look at the OCT, you can see the PED and the underlying membrane. Look at figure A, which is superficial capillary plexus, that's normal. Look at figure B, the deep capillary plexus is okay. Outer retina, which have been avascular, shows a clearly branching membrane. This is the neovascular membrane, and we can also be seen the chorocapillaris. So basically, this is a CNVM involving the outer retina and the chorocapillaris, which can be beautifully seen by the OCTA. So this is just a lot of patterns which we can identify, and a lot of studies are going on as to what are the prognosis of different patterns and how much of treatment may be required looking at the pattern of these CNVMs. Just to see, A is a CFAN pattern, which you can see all the vessels radiating in a single direction. B is a Medusa head pattern, where you see radiating in all directions. Okay. Okay, sir, I'll just conclude.
You can understand you are enjoying your description of specific facts.
Sir.
This is also important. Conclude. Just conclude.
Okay, sir. I'll
All these are very important for you to learn things.
Okay, I'll just conclude. So that's okay. So basically, CNVM and response to CNVM can be seen very well with the Nocta because you actually see the lesion. Okay, it's also a very important toll in pachychoroid. I'll just show the figure image as a patient with a CNVM with chronic CSR in A, in figure A. In figure B and C, you can see a leaking angiogram. And figure D shows the chronic CSR with some retinal fluid. And if you do a Nocta, then you beautifully visualize a pachychoroid neovascular membrane, which is the future. So, just to end, it's a very promising and exciting technology, but still we need to explore it much further to understand various pathologies. Thank you.
In the first slide, you didn't show where are you from, this place?
I'm from
Patna. So, thank you, Meha. With this, we come to the end of this session because we have to go to some other session also. So, thank you all the chairperson, all the speakers and audience. May I have a group photograph? Please come here.